Hello, everyone. This is not the easiest transition for me. Prof. Lim just, really lay out the plan and I have to come right after. So I'll try to do my best. I think we heard loud and clear that elevating patients' voice in health policy shaping is key. If I react to what I just heard to transition calmly, the most important voices, those of patients, the people most directly affected by any new law, have been largely unheard, and maybe even more so in this region. So without elevating the voice of patients and taking their thoughts to heart in forming the new laws, the country stand to harm the collective health outcomes. We've heard a few evidence points here. I think patients' voice should take precedence in any conversations about what the best health plans for the people should look like. But we also have health policy shaping, and for this, advocacy plays a key role in building strong health systems. And those advocates help ensure implementations of health policies, monitoring the impact of those policies, identifying gaps and challenges. Healthcare advocacy can play a vital role to ease the burden of patients' experience because they can navigate the healthcare system. But the question is how to best shape health policy Is there a playbook per country, per continent, per disease? Who knows how to navigate? And so this is why we have an extensive discussions that is about to take place with many, many experts. I'm going to call the first two, and I'm going to have to take my notes because they have 25 years of experience, so apologies. I have to read this. So Jeff Weisel has more than 25 years of experience working in access to healthcare, to medicine in Asia Pacific. And we know it's in Asia Pacific. He's been living in Singapore since 1994. His bio is really, really big. So I'll invite you to click on his profile in the platform. And then I will ask also Sejal Mistry, the regional director of Access Health Southeast Asia, to also join me. She leads the Health Futures programs at the intersections of innovative health financing, digital technology, and service innovation in Singapore. She's also previously worked with the South Korean Health Insurance. She also has been a senior health policy advisor to the US government. So they have some of the experience that are needed. So let's invite them to join me on that stage. Hi, Sejal. Hi, Jeff. How are you?
Good afternoon.
Afternoon. Thank you for the warm introduction, Maryline.
Well, it's easy when I have to deal with experts. So I know the two of you have 100 million things to say, and we're going to have to do it in 12 minutes. When I say health policy shaping, I'd go to Jeff first, but is there a clear understanding what is health policy shaping? And is there a difference when we move from one country to the other?
Jeff, I'll let you take that first, but I do have some comments to share. Go ahead.
Well, I guess yes and no. Countries are all unique in their own way, but we can look at commonalities where each country has people making similar decisions, similar organizations. They may do things in different ways, but ultimately they're working on the same goals.
Thanks. And I would agree with Jeff. I think at the heart of it, what we are really talking about is in representative governments of those government representatives really being able to reflect the needs and the desires of the people. And so when we're talking about patient advocacy and health policy shaping, the end goal is not to put legislation on paper. The end goal is to actually have effective, responsive health systems that actually help enable better health outcomes and better health experiences for people. So I think this is a goal that is common to all countries, no matter what shape the health policy system may take in one country versus another.
So I'll cheat, but I've asked Jeff the questions. Can you put on the whiteboard a cheat sheet of how does it work? Jeff, do you have your cheat sheet?
I do, if someone's going to put it up for me.
I think we need to go to the next slide. Yeah.
Very good. Okay. As Maryline said, you know, we spent a lot of time in the last few weeks talking about this question, and you know, one of the things that came up is, you know, the idea of shaping health policy actually sounds quite abstract. You know, it's you know, what does it actually mean? And you know, and then it comes down to, you know, different organizations and agencies within government that make certain decisions that guide it. But in a way, you know, organizations don't make decisions, it's people who make decisions. So I think the one way we thought about it was, if you take a step back and understand that there are people in each of these organizations or agencies that are actually making the decisions. So you have people, for instance, making decisions in regulatory, like Professor Lim, deciding which, if a therapy or a vaccine or medical device is actually meets the medical needs of the country, and then it goes to you know, people deciding who will the product be paid for? Will government reimburse it or fund it in another way? We talk about a little bit later, we're going to talk about health technology assessment, or HTA. That's just one way that governments make decisions around whether a new product meets clinical and economic needs, and as well as how it compares to other options. And also, by the way, this can be done by government, or it can be done by private payers as well. And a third area of decision making is around we call formulary, but it's essentially, you know, is the product, even if it's approved for use and even is it funded, is it going to be available in your local hospital or clinic and get on, you know, essentially be on the shelf so doctors can use it? And that decision can be made at a national government level. It can be made at a local government level. It could be made at an individual hospital. But again, people are making those decisions, not sort of an abstract organization. Above all that, of course, we have people who are making policy decisions. So above, if you want to think about it, a product-specific decision, it's more general. You know, how will you know, people, patients in a country use the system? Which facilities do they go to? What's the thinking for at a disease level around how are we going to, as a country, manage diabetes, for example, right? So this is the policy level of decision making, and above all that, of course, are political decisions. There are ultimately governments, legislations that have an impact on health policy decisions when maybe weighed against other decisions like infrastructure, or transportation, or education. So these are all areas where people are making decisions. Now, when you think about then of the people making decisions, we can borrow the phrase, know your customers. So it's actually, how well do you know what motivates the people who make decisions? And you have to ask yourself some basic questions. First of all, who are they? Who are these individuals? Who are the people that either make the decision or influence the decisions? What do they need? You know, what is the objective? What are they trying to get to when they make these decisions? Very important, then we're going to discuss a lot about is how do we reach them, right? How do we get access to them? How do we have conversations with them? And the last point is then how do we, you know, what we as an advocacy group, how are we addressing what it is they need in their decision making? So it's all sort of very, I guess, fundamental questions, but it really comes down to the end. I'll leave with a thought is, you know, when you're trying to influence policy, really you're trying to influence decisions made by people. And so if you approach it that way, maybe it becomes more accessible, less daunting process. So I'll leave with that thought for now, and maybe turn back to Maryline.
Yeah, well, I think I want to hear Seja react. I think we understand there is a structure, and we understand that it's all about people. And Seja, you've worked with a lot of patient advocacy groups, and you've worked a lot on access. Is there some differences? Is there some commonalities? I mean, what did you see in your research?
Yeah, sure. And I'm going to also take the opportunity, since Jeff had a slide, to also put up a slide myself. We did do some preliminary research, and I'd love to maybe at some point talk to Professor John Lim and compare notes, but we did do research into PAG involvement in 12 countries throughout Northern Africa, Middle East, and Asia Pacific. And we looked at specifically, next slide, sorry. We looked at specifically what is the level of PAG involvement in different phases of the HTA process, and kind of developed our own metric. And one thing to note is that if you see sort of yellow is highest, pink is intermediate, blue is low, and green is none, probably not the best color ranking. But what is really interesting to see here is that there's really a mix of the types of countries, what one would consider high income versus low income, strong health systems, low, sort of weaker health systems in terms of PAG involvement. So, you know, yes, the challenges are there in trying to know your customer, figuring out the different processes, capacity, all the things that both Jeff and Professor Lim had articulated. But at the same time, every country, when you get to know your context and your political structures, and importantly, the people beyond those political structures, there are ways to get involved. So you could be, you see Australia, Philippines, and India, you know, at the top, and these are very different countries. And again, you know, this could be debatable how you rank them in different types of processes. HTA is just one part of the policy process that we illuminated here. But if we go to the next slide, I want to highlight also throughout this process, we talked to a number of PAGs and found out a couple of common challenges that are going to sound very familiar to you, because it's many of which that Professor Lim and Jeff had also stated. One is really on channels and messaging. What are the official and unofficial channels of communication with policymaker? And again, this is what Professor Lim had emphasized of how do we formalize that engagement? Do they exist in place? Are they meaningful modes of engagement, or are they sort of token patient input? And so the more we can get to formalize structures that actually value patient input as both being necessary as responsive health systems, but also as important data sets, then, you know, this is something where, you know, the challenge that we face here, once we work on it, can actually make for better engagement, but also better healthcare and better policies. The timing, how frequently are patients engaging in decision-making process? Is it a once a year thing? Is it an ad hoc on a platform? Do input get sent out into the ether and then you have no idea what has happened when you've actually sent out an online form about your patient experiences? Is it being heard? Is it understood? And is it persuasive? So one is really under communication channels and messaging. The next slide, please. The next one, again, is knowledge and capacity gaps. Again, Professor Lim had articulated this really well as Jeff, is you guys are stretched for time, for resources. You are experts in your own diseases. Now you have to be experts in the whole policymaking process. So part of it is helping figure out what is the way that you can better understand the stakeholders, their processes. Are there ways to upskill through training and mentorship? Does that mean PAGs support other PAGs? You know, there's not really a diploma in the work that you guys do, but are there also formal ways and semi-formal ways that you guys can kind of get ahead and heard and be more effective in your engagement with policymakers? And the last slide, please. The last, and again, I was happy to see Professor Lim mention it, is really having integrated standardized data system. There's probably no one in the healthcare ecosystem that hits all points of the healthcare system like the patient. So instead of being facility-centric data where, you know, the ministries might collect from tier 3 hospitals, tier 2 hospitals, primary healthcare, et cetera, what we need is patient-centric data sets. You really get a holistic picture of the patient experience, the patient's condition, and that's not happening in many countries. We're starting to see this happen in places like Thailand, in India, in Singapore. But I think when Professor Lim had mentioned having these data sets that really are structured and define the patient experience, you will come in with a lot more credibility and strength. So it's not just PAGs coming in with anecdotes, but PAGs coming with evidence-based anecdotes. And that's going to matter because it's really about strength in numbers as well. So next slide, I think this is it for me.
Yeah, I think that was it. Thank you, Sejal.
Maybe, yeah, no, go ahead, Maryline, please.
No, I was going to ask Jeff if you wanted to react before maybe we go off to actually those that have done it.
Well, no, I think the challenges that Sejal said are quite clear. I think one of the things that strikes me is you know, be open to innovation, the way you approach these things, and learn from, you know, learn from each other, learn also from outside. When I said know your customer, I did that for a reason, because there are ways, let's say, from, you know, retail or consumer industry, where they learn very well how to understand the motivations of people making decisions, right? So be open to ideas from anywhere, you know, as well as you know, focusing on making your message clear and data-based.
Thank you, thank you. Do we agree we bring the real people? We feel like we're missing the actual case study. So I'm going to ask Joy to tag along, not to say that you're not the real people, let's be realistic, but experts versus those that have done it. So Joy, do you want to join us on that screen? I don't know how it works technically, but Joy should appear, join us, and has all the cards in hand to introduce us what's coming next. Nope, it's full screen. Yeah, it's Joy.
Thank you, Maryline. Thanks for letting me join the party. And I'm very excited to welcome everyone to the next part of our session. It's been a very interesting conversation so far. We've heard Jeff and Sejal talk about what is necessary to really drive patient advocacy successfully. And we've also heard from Sejal what are some of the key challenges that deter PAGs from meaningful inclusion in policy shaping. So now we have invited actually 4 people who I think will agree that yes, there are several challenges, but they can attest to the fact that it can be done. It can be successfully made so that the patient's voice is heard during policy shaping. And, you know, we really went around the world to find these people and learn from their experiences. And I'm very excited to introduce them to everyone. First off, we have Derick Mitchell. Derick is the CEO of the Irish Platform for Patient Organizations, Science and Industry, or APPIPOSI. Derick has a reputation within the health policy research and patient advocacy fields for being able to persuasively inspire and execute future vision and strategy. And most recently, he led the development and implementation of an Irish patient education program in health innovation with public and private sponsorships. Next, we have Tanya. Tanya is the CEO and founder of Hearts for Hearts, an organization which she has founded in 2011 through her own experience of living with heart disease herself. Hearts for Hearts is an organization which supports, educates, advocates for Australians living with heart disease. And Tanya has been the recipient of the 2012 CALI Award, which stands for Community Action, Leadership, and Inspiration. Following Tanya, we have Ms. Carmen Auste, who's really a multi-hyphenate when it comes to the patient advocacy sector. Ms. Carmen is the Vice President and co-founder of the Cancer Coalition Philippines. And she's also the co-founder, chief executive of the Cancer Warriors Foundation. She's a member of the WHO Working Group for the Global Childhood Cancer Initiative and member and co-chair of the Technical Committee on Patient, Family, and Stakeholder Engagement of the International Society of Pediatric Oncology Program for developing low-resource countries. And Carmen is a mom of a childhood cancer survivor, and she has spent the last 4 decades really advocating and providing technical guidance and support in cancer advocacy across more than 40 countries. And last but not the least, we have our very own Dani. She is the worldwide access product lead from Novartis Oncology, and she has over 15 years of experience in the pharma industry, fostering business government relationships in targeted disease areas to enable patient access to innovation. So there you go. We have these 4 panelists, and can I invite everyone to be on the screen? And yeah, your time and knowledge today. And why don't we kick off the session? Maybe we can start with Derick. You know, usually we say ladies first, but I know that you're joining us very early in your day at 7 in the morning, so I must give you the privilege of starting first. You know, Derick, when we hear of Ireland, and we didn't see this in the slides of Sejal earlier, but I must imagine that in Ireland, the healthcare system must be already quite mature and maybe everything is all figured out. I want to hear from you if this is really the case. Maybe you can tell us about your work in IPPOSI and how you're able to engage with the HTA.
Thank you, and I hope you can hear me okay. And my apologies for the rather unusual sight on my screen, but the sun is actually coming up in Ireland, which is a rare enough event. So we're please excuse that. But thanks for the invitation today and wonderful presentations so far. And yes, there's a great deal of consensus about what needs to happen here and what the challenges are. I think when I think about Ireland, I would probably put us on that kind of intermediate level rather than maybe advanced level. I think no matter how maybe advanced or structured a system, a health system may seem from another country, always the reality of it is quite a mixed experience. And certainly the HTA process and the patient advocacy area is quite a mixed experience for those of us who have been working in the area for a number of years. So the organization that I am here to introduce is our own organization, which was set up by patient advocacy groups over 15 years ago. And it was set up to kind of, when Jeff and John talk about the difficulty of getting access to policymakers, IPPOSI was set up by patient groups to provide, I think, what you might call neutral spaces. So it was a place where policymakers could be comfortable joining and speaking openly, as relatively openly as they could, within a space that was a multi-stakeholder space. So IPPOSI was founded by patient groups who recognized that they needed this. It was kind of like a think tank model, but we've since progressed over the 15 years of our existence to a think and do model. And there's been several influences on that. I thought it was interesting when John said about that lobbying in Asia Pacific is traditionally seen as a negative word. And certainly in Ireland, that was the case when IPPOSI was set up. And we had to very much promote ourselves as being a non-lobbying organization that was founded on the basis of consensus, on dialogue, and on being patient-led. Whereas in the meantime, we've grown to such an extent that almost we're probably the largest patient network of both patient groups and individual advocates. But we also have over 200 academic scientists as members, and we have 23 members who come from the healthcare industry. So that kind of an environment is actually now recognized in Ireland as an official lobbying. So we had to register as part of our activities under a lobbying register. So lobbying became less of a dirty word because it was very much part of the fabric of what we were doing anyway in terms of communicating and interacting with policymakers and indeed politicians. So over the years, our work has been in many areas. HTA has been a very a real focus. But if I was to give an example of the kind of impact that we've made at the policy level, it would probably be in the area of rare diseases. And I have two photos that I think came up earlier on, but I just wanted those photos kind of encapsulate everything that we've managed to achieve in the rare disease space. Because we were able to use certain levers from a patient perspective that influenced the policymakers to generate a national plan for rare diseases in Ireland. And that was a very broad plan. It covered all 8,000 or so rare diseases in Ireland. But from the policymakers' perspective, it was pitched as a generic policy framework. And it was so important to get that because we didn't have the, I guess, the mandate or the ability to get legislation implemented or designed. But we did have because Ireland is a small country, we did have the connections to the policymakers and the politicians. And the generic policy framework allowed the development of the plan through a multi-stakeholder approach involving several policymakers, but it wasn't officially developed by the government. So what what that did was that it allowed the patient groups to lead on certain aspects of the development of the plan. And IPPOSI was the lead for the development of the section on orphan drugs and technologies. And patient advocacy groups were members of, once the plan was published, the oversight of its implementation. So that plan was published in 2015. We were able to leverage certain levers coming from the European level as well, because the European Council had mandated member states to develop these national plans. So there were a number of policy levers that we were able to use that, to speak to Jeff's point about, you know, what motivates people at the decision-making level to act. These are the kind of levers that we had identified in advance that said, okay, this is what we can do based on the resource that we have, based on the connections that we have, based on the mandate from the patient groups that we have. So, and since the development of the plan, and because we have oversight of the implementation, we're able to identify where the gaps are. And there's since been a number of advancements since the development of the plan that have been primarily down to the pressure that we've been able to apply together with a number of patient groups in Ireland. So that's just a very brief example of some of the impact that we've made. Thank
you, Derick. I don't know where we are, but if anyone can hear us, hi, we're back. Thank you, Derick. I think this was fabulous. You stole one of the questions that I had. What are the influential levers? But I think you've said it. I think I heard knowing the people was not enough. You need to understand them. So I think it's good. And it looks like you have figured it out a little bit, but it's not figured it out completely. So still a way to go in Ireland, but you're still leading by example for us here today. So I know we spoke a lot, Tanya here. And Australia seems to be probably also in this region, maybe mature. And we've seen earlier in Sejal's slide, yeah, you were at the top of an engagement, if I can say, yeah. So sort of you have your place. Somehow we're hearing you, but I'd like to hear from you concretely what has happened, and please introduce your associations and your story, and maybe through concrete examples. Were you hurt? Might be the question.
Yeah, you know, I think sort of touching on what Derick said a little bit earlier, that, you know, I think while we've come a long way in the HTA process, there's certainly we still have some work to do. You know, it's certainly not perfect, and there has been times that I've been involved in policy discussions, and, you know, it's quite evident that it's tick off the box. But I do think that, you know, even over the last 2 years, that there's been a lot of improvement, because there's been a lot of reviews taking place, and so patients have been really vocal in that process. But in terms of our organisation, as you mentioned, I founded Hearts for Heart in 2011, and it was through my own experience of having a heart condition. And we run national awareness campaigns, we provide peer support and education to patients, and we do a lot of advocacy. So whenever there's a new listing for a medicine or a device, then we'll provide input to government. And we also provide a lot of input in terms of any health policy reviews, and we get involved if there are any barriers. And so it's a great opportunity to speak today about one of the case studies that I thought would be helpful to talk about. And it's funny because I had identified the issue very early on, because I needed a procedure myself, and I was in and out of emergency, you know, 2-3 times a week, and I had to wait 12 months for this procedure. And this is before I founded Hearts for Heart. And you know, I remember writing to the health minister back then, and it was the first time I'd ever really done anything in that space. But and obviously, you know, was ignored. And then, you know, sort of maybe 2 to 3 years in at Hearts for Heart, the clinicians that came to me and said, we have a problem. We've been advocating in government for the last, you know, 10 years with industry to try and get this procedure, which is called a catheter ablation, to treat atrial fibrillation, listed in private hospitals, because it wasn't available in private hospitals. It meant that there was a huge backlog and wait, you know, up to 2 years for some people, waiting for this procedure. And so what I did initially was spoke to other stakeholders to understand the issue and the barriers and who it was that we needed to engage with. And because I hadn't done any advocacy with government, I thought we really need to source an agency that can provide us with guidance in terms of what's the best way to go about it, who are the politicians that we should be engaging with, who has an interest in health and all of those types of things. And so the guidance that we received was fantastic because we were already running awareness events. And so they said, run the awareness event in Parliament, provide free screening for politicians. And during that time, we organised meetings with politicians who have an interest in health. And, so it was a profile raising exercise of the condition, but also to explain what the issue was and how many people were affected by this and the consequences if patients didn't have access to it. And so that was part of the initial strategy. And then because we found champions sort of within government, some of the MPs, they then would, there was activities they could do with themselves to raise the profile. So they'd raise it in the House of Representatives and so forth. And so, we were really lucky to find that support, but that support is available, in most governments. You just need to be able to identify who they are, who has a special interest. Following from that, we knew that we were obviously in government's ear. We knew that industry were in government's ear and clinicians were in government's ear, but they also have their own agenda. So it was really important for us to understand what their agendas were and what were the roadblocks of them listing it, which in our case, which is the private health funds. And so what we decided to do was bring everyone together to bring a unified voice to the issue. And so we created a white paper. And I thought, this is an opportunity for me to bring together the clinical societies, so the Cardiac Society of Australia and New Zealand, the Heart Foundation, Stroke Foundation, GP, primary care bodies, and industry, so that together we could talk around a round table and say, right, atrial fibrillation is a growing epidemic in Australia. What do we need to do as a community to work with this issue? What can we implement? What are the sort of the key things that we can really work towards over the next few years? And so out of that came some recommendations, which of course was early diagnosis, so screening, better education in primary care, and of course access to this therapy. I mean, there was obviously the list is much longer, but it really it meant that this white paper was able to demonstrate that we all had the same views, that we all really believed that patients needed access to this therapy once that they were diagnosed. And we launched that in Parliament. And so, that it then became really difficult for the government to push back on that because, not only, industry and clinicians and, all the clinical groups and patients are saying we really need access to this. And of course, part of the strategy was knowing when to go to media and when to be more vocal if there were, pushbacks, which there were. And we really leveraged on the relationships that we had with our stakeholders because, something was going on behind the scenes. We needed to know about it so that we could then strategize around that. And, and that really sort of helped us, I suppose, when planning, because, we just most definitely did not want to give up until patients had access to this.
Do you mean that you were a little bit persistent in trying and trying? And I'm only reacting to the first two here that have given their example, but I feel like we often think that it's going to be easy until we do it, but it's actually a real job to learn how to do it. So there's a lot of things that you've said here. And I must confess, I did write a letter when a few years back because I wanted to ask someone in my country to give access to a drug to my father. but I did write to the only person that I knew. It was the president, yeah. And do you think that helped anyway? No, it didn't. But I think we have to be realistic. A lot of people like me, until they meet real people like you that are actually really pushing into professional level, it's not happening. We don't get any response. We don't get any answers. So I feel like you're giving us the journey, which is not an easy one, the persistence that is required, but also the knowledge and the experience that you've just gone through. So it's not only a question of the maturity of your country. We often think, oh, Australia, Ireland, they figured it out, they know how it works, but it requires a bit more. So that's what I heard in those first two examples, if I may. And I want to point out to Joy, if we can bring her back. I think, I mean, Joy, take us to the journey into Asia Pacific, because
actually it was really great hearing the experience of Tanya, and I wanted to see if there's a similar experience in the Philippines, because we saw earlier on in Sajal's slides that Philippines is one of the countries which has high levels of PHE involvement in HTA. So and I know, coming from my experience, I'm from the Philippines, and I know how NGOs and patient leaders from this country are very active, they're very engaged, and they're very passionate. And even on the national level, a lot of the change is expected from the private sector. And I want to ask our next panelist, Carmen. Carmen, your organization was really instrumental in the passing of the National Integrated Cancer Control Act, as well as the Universal Healthcare Act. Maybe you can share with us your journey and what really jump-started the initiatives for these.
Carmen, I think you're on mute, so we need to get your mic up.
Yes, thank you very much, everyone. Yes, the journey of the passage of the NICA law and as well the Universal Healthcare Law is very much interconnected with the story of Cancer Coalition Philippines. In early 2017, 5 national NGOs that had previously been working on cancer, but on specific types of cancer, decided together with 2 medical oncology societies that it was time to speak with one voice and to act as one. So rather than just advocating for like cancer warriors with childhood cancer, with some with breast cancer, others for registries, as well as other initiatives, we decided it was time that we spoke with one voice. And what actually inspired and propelled us as well was the fact that in May 2017, in the World Health Assembly, there was passed the resolution on cancer, referred to as cancer prevention and control in the context of an integrated approach. Myself, as part then of Childhood Cancer International Global Network, was also very much involved in advocating for being able to integrate children and adolescent issues and concerns in that issuance. And as well, it was also during this time that the advocacy of childhood cancer groups to integrate childhood cancer in the global health agenda, both of the United Nations and WHO, came to fruition. So the colleagues that I had felt, if we could do it, if we could engage and advocate successfully with WHO, we can do it in our own country. And what also helped was at the time, the call for the WHO resolution was to be able to translate and transform the global commitment into local action. And our country was one of the signatories. So it is actually this document that we shared with the key decision makers as well as with our legislators.
That's a great start. It really shows how strong a voice is when it's banded together. So from the time that the 2 cancer groups formed in 2017, how long did it take for the law to get passed?
Actually, the Cancer Warriors Foundation and the other groups have been existing already for 15 years, and one even existed for 50 years. It was just Cancer Coalition that was like the baby of all of us coming together. And we actually had a breakthrough in that usually in our country, it takes 3 congresses or about 9 years to pass a law. In the case of NICA, it took only 1 year. It was signed into law on Valentine's Day, February 14, 2019. And the president said it was his Valentine's gift to all the cancer families, their patients, as well as the survivors too.
That's really a memorable date. And I think what your story also shows me is the importance of being able to find the right partners, being able to find the right champions to push a certain cause together. So in this journey of yours, who were the key partners, and what was your approach in terms of engaging each one of them?
You're
Carmen, am I still on?
Yeah, you were sort of breaking up, but I get the question. Yes, collaboration and complementation was a key component of our strategy. And we decided we were going to involve everyone. People said it was ambitious, but we said we have to improve everyone because there has to be a sense of ownership. There has to be sustainability. And if one group feels left out, then we will not get that sense of ownership and support. So we actually went through 3 phases. The first phase was in terms of being able to engage and consult. We started off with the power mapping of our legislators and key people, not just in terms of their interests in cancer, but as well whether their lives have been personally touched by cancer. And we prioritize them in terms of individual meetings with them and their staff because eventually they became the champions. We didn't have enough data, but we had stories both from our members and as well from the legislators themselves. And that became a very powerful and compelling message. And then we engage as well with all the possible medical societies and professional organizations. And in one meeting, of course, in separate meetings, because there were so many of them, one of them said, this is the first time in years we've ever been together in one room, we've ever talked together, we've ever been in this friendly mode of collaboration rather than competition. And then from there, of course, the parents, the patients, the survivors, their families, we had town hall meetings. And through listening to them and their needs, interests, and preferences, we were also able to identify potential champions that can then be involved in the next phase of being able to amplify the voices and spotlight these compelling narratives of their experience and cancer journey. And not only that, we decided that the pharma had to be involved because, truth to tell, we felt that the pharma industry could be a possible oppositor if we did not involve you. We knew as well that there were certain points that you saw from a different perspective to patient groups. And we felt if we brought this together and with the triangle of government perspective as well, then the law would be something acceptable to all, supported by all, and it would be accelerated in terms of implementation. We even had regular meetings with the pharma group in order to be able to update them in terms of this is what is happening, et cetera, et cetera. And we decided, and this was upon the advice of legislators, not to directly oppose people like those belonging to the insurance community, that there could be things that they could put into the law that did not necessarily put us in direct opposition. So we did that as well. So it was really whole of government, whole of society. The very important aspect, the second phase, was in terms of being able to deepen the dialogue and being able to have, again, various mechanisms by which the various groups could dig in to the issues, to the content. We actually wrote the law ourselves. We're always asked who wrote the law. They thought because we were engaged with pharma, it was pharma or consultants of pharma or lawyers. They said, no, the patient groups wrote the law. But what guided us was the framework of the WHA resolution. And as well, all of the inputs that we got from the different information. The final part that was most exciting was that when we were having the hearings in the legislative houses, all of the different groups brought all of the patients, their families, and so on. And for the first time, the legislators were so aghast because they were saying, the whole floor is full and the ground floor as well. What do we do with all of them? Because this was the first time they said that there was such an issue that really they could see everyone. There were children, there were the elderly, there were women, there were the persons with disability. And at one point, we were supposed to be at the end of a long discussion, but one of the legislators stood up and said, all around us are people with cancer and their families. Can we make them top of the agenda? And they did. So really the power, not only of amplifying our voices, but putting a face to cancer or to any other disease. Because oftentimes it's true, evidence-based is important, data is important, but we still feel that when they see them, when they interact with them, when they hear their stories, or when they themselves have in touch with whatever disease we're advocating for, it becomes a more powerful push, a real motivator in terms of sparking action.
Thank you for that. It's amazing. I mean, just listening to your story, I feel like it was so well thought of, that it was so structured, and it seems like you ticked all of the boxes. You did everything correctly, but I'm sure you also managed to with several people. You worked with several stakeholder groups.
The reality was we did not label these things that I'm telling you now. I mean, we did not say this will be this and this. It's like as we were going through the stages, guided only by that principle that it had to be inclusive, it had to be participatory, we had to be able to put front and center patients and their families. Because in our culture, even when you're 30, 40 years old, when you're sick with a sickness like cancer, the family is still part of the picture. And so that's why you'll see in our statements, it's not just patient and people-centered, it's also family focused as well. And of course, in terms of the different stakeholders, we had to listen to them, but the key challenge, I think, is being able to weave together. What are the intersections? What are the cross-cutting concerns? And it was that became the frame of the cancer law.
I see. And if you could summarize, like, what were the key learnings that you got from out of all of these milestones and through your long journey, what would they be?
When I was trying to reflect on the best lessons, I recalled that as we were drafting the bill and as we were putting in the asks, a lot of people would say in our language, sobro naman kayo, or that's too much. You're asking for the moon and the stars. And we would always say, well, at least if it goes down, we're still on Earth. If we only ask for the Earth, we probably will get very little, because there's a tendency, as we know, for things that you ask to be minimized down the line. And so I think one of the best lessons that we have is to think and start with the mindset, nothing is impossible. If you believe in something, if you find and expand your collaboration to beyond your traditional partners, because most often we tend to stick to our traditional partners. With us in the Philippines, there's a very strong senior citizen organization because we have a senior citizen law. So we engage them as well. They didn't need to be focused on cancer. They could be focused on NCD, HIV/AIDS, anything, for as long as they were concerned about people who had cancer. So that was one of the lessons. And then the second one is how powerful the stories and the voices of patients are. Since we did not have enough data at that point in time, this became like a proxy indicator. The experience became a proxy sport. And of course, the fact that legislators themselves, and eventually even our president, because we did get to see our president to his first partner who's a nurse. We were actually just engaging her, and he appeared and he said, how come you don't want to meet with me? I'm the president of this country. And we had to tell him we weren't sure we could meet with you, but we could meet with your first partner. And that was why the bill became a priority in the legislature and went on so fast. And finally, as well, this thing of complementation. There are things you can do, we can't do. There are things that I can do, you can't do, but together, we will be awesome. And I think that is part of health policy shaping. That's why we have all the different stakeholders. Together, we are awesome and we can make changes everywhere.
That's great. And that's exactly, I think, what we're trying to do with APPIS.
Joy, will you allow me to ask a question? And it's just a reaction, Carmen. I didn't rehearse this, but I feel that, and I spoke a lot with Tanya, who works in cardiovascular, so I'm going to put you on the spot, the both of you, and I know cancer as well. Like I said, I mean, we're often touched and we don't want to be touched by cancer, but it seems that cancer could be heard a little bit more by some of our politicians versus cardiovascular. And I'm just wondering if it's because I saw a lot of the comments and the chats, and, you know, cancer is, we're scared of cancer and we have to admit it. Is there something that you feel one or the other that is played in your favor, which is not a good word? I don't know what to say here. It's probably not in your favor that I should say, but you understand what I mean. Or does it play against you? Because cardiovascular is the number one killer in the world, not cancer. And not that I want to compare or fight, yeah? But the two of you, you work in the same field, you're trying to achieve the same thing.
That's
Okay.
a good question, because actually that was part of the opposition that we were having. If we pass a law on cancer, what would keep people with cardiovascular diseases and all the other NCDs from wanting to have their own law? What makes you so special? And then we said, well, in terms of cardiovascular, which is number one, and where we had a lot more programs and a lot more resources as well, we said that we are not competing with the other diseases. It's just that the costs of cancer is more catastrophic, the treatment is longer, and the chance for having life-limiting and life-threatening is also more intense. So that's the way we put it. But they were trying to make us compete with other diseases, including cardiovascular.
Tanya?
Yeah, I mean, in Australia, I think cancer certainly has a lot more funding right from beginning to end, right? You know, right from research through to, you know, with awareness, there's much more awareness. I think you're right that people are, and because celebrities tend to talk about it, and this is a known thing even in PR here, that heart disease isn't a sexy disease. I don't know what disease is, but apparently from a PR perspective, you know, that's the issue. You know, again, celebrities are really willing to talk about it because it's not going to affect them in a negative way. Whereas for whatever reason, I think there's still this misconception that heart disease affects people that aren't, you know, only affects people that drink or smoke or that are overweight. And so there's that negative connotation, right? Whereas, you know, that's just, there's many different types of heart disease. And so it's been really difficult getting champions, you know, ambassadors to speak publicly about it and get the same kind of traction, I think, that what cancer does here. And like I said, I mean, research, this is literally from research institute to, you know, government funding, really at all parts of healthcare.
In our country, the reverse is true, though. Cancer for so long had been like a neglected disease. And so it was like, you know, we were really trying to show them. And I think what also helped was telling them that by 2030, WHO said that there will be an 80% increase in new incidence of cancer. And if we don't do anything now, the price of inaction will be great. But we also always say that cancer is a walking NCD. So we always carry in all of our messages cardiovascular diseases, lung diseases, diabetes, and now the autoimmune disorders like psoriasis.
So Maryline, I think for the last 9 to 10 minutes, I want to turn over to Nidhi, who I think will be able to share a different perspective in her experience. So she comes not from the patient advocacy group space, but from somebody working in the pharma industry. So Nidhi, as an industry leader, you worked with patient advocates in India to create an advocacy group to drive policy change for sickle cell disease. Maybe you can start us off by telling us what the background was for sickle cell disease in India, what the situation was for patients and for patient groups, and what was your journey? What was the journey for patient engagement?
As presenters.
Thank you very much, Joy. Actually, Maryline, that was a very good segue to you know, what I'm going to speak on, which is how to start from absolutely nothing. And sickle cell is a disease that a few years ago, not a lot of people knew about it, except of course the patients who suffer from it and the treating physicians. So I wanted to share a story that I witnessed as a Novartis partner with an absolutely great patient group, the National Sickle Cell Alliance of India, and how that grew over the period of a relatively short period of time. And you know, what I saw as some insights that could be interesting on how to start from nothing. So just a very, very brief background about sickle cell disease. It's a hemolytic disorder where basically your red blood cells take a form of sickle, and that leads to a lot of complications, not just that you have anemia and fatigue, but also when those sickle shapes in the blood, they get stuck somewhere, it causes a lot of problems in your organs, as well as in insufferable pain. Yeah. So it's a genetic disease, and one of the key challenges of this disease was, unfortunately, it targets, or that's how the incidence is, the patients which have historically low socioeconomic background. Yeah. So, for example, in all over the world, it's very prevalent in the tribal populations of India. It's very, very prevalent in Africa, and the African and Indian origin population in other countries such as US and Europe. So one of the issues that we had when we started was there was not much treatment in the last 40 to 50 years, and the voice of patient was really non-existent. This is a specific story about India, where we have about, it is estimated that there are about 1.2 million patients with sickle cell disease, and they have very limited access to not just sickle cell focused healthcare, but just any healthcare. And clearly there was no patient advocacy group before 2018. The focus of the government was on other blood disorders, mostly thalassemia, which is also quite prevalent in a country like India. And there was not really a lot of voice. So how did that transition? So if we go to the next slide, basically, it is, again, I share with you from a viewpoint of how we saw as Novartis this journey. When we started in 2019, or in fact in 2018, there were very few patient voices of sickle cell disease. And if they were within some thalassemia groups, which is, as I said, another blood disorder. We happened to start a project on just identifying and understanding. These patients live in very, very rural and tribal areas of India, where even physical access to those areas is sometimes hard. So what we started was just a storytelling project, accompanying a journalist and understanding who these patients are, what do they look like, what do they go through, just as a part of a video journal. And through that we connected through a few patients. Yeah. And we with that it started on doing a little bit more understanding of what these patients are, what the actual burden of disease is, the estimated numbers of the government versus what the actual numbers are, and advisory boards through the physicians and the patient societies. What we did understand doing that exercise was a discovery of a very, very unconventional partner, which was not the Ministry of Health, but the Ministry of Tribal Affairs in India, which had, interestingly, a very a good connection with the patient community that suffers from this disease. And in mid 2020, there was a big event organized on the sickle cell disease conclave, which was led by this tribal ministry that focuses around, again, a multi-stakeholder discussion around what these patients go through, what physicians think about this disease, what the policymakers have as a current focus of this disease, and of course the viewpoint of the pharma. And that led to actually the leadership of the tribal ministry in this case. The tribal minister had also personal stories where his family was affected by sickle cell disease, so they could really lead this initiative in terms of understanding, what is needed for these patient community. They announced a registry on collection of data. The sickle cell disease, which was these few scattered patients, through the means of various projects, got together and created the National Alliance of Sickle Cell Disease in India, which became a really formidable formidable a voice now, starting from 2020. What also came as a conclusion of these activities was the government of India formulated a National Sickle Cell Disease Council, and that included, the members of this patient organization. This was super interesting because this National Patient Alliance has been so active and inspirational in mobilizing now the resources that the government has provided them in terms of partnership with patient organizations beyond India, continuous dialogue in what can be done from now policy making to actual work on the ground, focusing especially on screening and diagnosis, as a one voice towards governments, the pharma industries, and of course the healthcare providers, and have that disease awareness amplification going on. So this was, the journey that started in 2018 up to 4-5 years. It's relatively short, but I'm really inspired with what they have achieved. What I took away, if we go to the next slide, as the key points that could allow this patient organization to start, one of the things was, this need of having that mobilizer. It could be a role of that, again, starting from nothing, patients suffer when their voices are not heard and they perhaps do not know who to contact. It might be a good idea to look at who shares a common interest with you. It could be an organization as Novartis in this case, which could provide a Rolodex of contacts or its network, but it could also be a very motivated and engaged physician or a scientific society that could allow access to either funding, access to resources, access to stakeholders, and access to, of course, skills and capabilities needed to build a broader group. So I think that's a very good idea, and one of the things that you can do in order to find that mobilizer is be alert of those bat signals through conferences, through publications, and through even media on who can have that shared interest with you. The second was, of course, it's not true that no patient organization existed before 2018, but there were few patients that were active within a broader group. So importance of connecting the smaller patient group into a unified national voice is very important, especially in a country like India, which is huge and very fragmented when it comes to the healthcare system, for the government to take it seriously. It was one of the things. Now the National Alliance of Sickle Cell Disease sits with the government on the council, and that is because there was a unified voice, and they are very active now in sharing that. Of course, it's a small journey, but having that persistence in sharing the inputs and dialogues, and in this case, it was just understanding of what the disease. For many years, sickle cell disease was downplayed as just anemia in some cases because they take a lot of morphine for their pain. Sometimes even a taboo or stigma that they are drug addicts. That needs to be taken down, and that needs a lot of courage and personal motivation and persistence. So I was so happy to see that coming across with this patient group, and shout out to them if they are in the audience. So I just, Joy, I would end here, and I wanted to share these 3 learnings that I got, as a witness to the journey, what they created.
Thank you, Nidhi, for capturing that super well. I was in my head, I was going to ask some questions, but you summarized all the answers I wanted to ask you. So thank you so much for that. Maryline.
No, thank you to all of you that have given, and we're not finished. We're going to finish. I think we have a poll to go so that we can engage in the conclusion. And I think, if I'm correct, the question is, you heard Rod summarize what was the poll outcome yesterday about the level of engagement, and I think we want to ask you, after these 4 incredible, story through one of their case study, I'm sure they have hundreds, how confident do you feel, that okay, I'm going to start again. How confident are you?
Maybe we can ask help from Sunil. Sunil, can you maybe bring up the poll questions for our audience?
That would be a good thing. Put the question up, but how confident are you about, your level of engagement and elevating the patient's voice in health policy shaping? So take the time. There's a QR code somewhere. Take the time. We give you the time. But I wanted to react to this, and I've seen a lot of comments on the chat and people asking. I think there's so much passion, but so much dedications to each of you, and you've given your journey and some concrete examples how to take it. There is so much sensitivity as soon as we talk about a country, as soon as we talk about a disease. And I can tell you, I was raised by a nurse that has fought an entire life for a genetic disease for one of her children, and it's not me. It's been really hard to see her do this, and she had to search for the professional support. The professional, I call you the professionals, because this is so hard for a mother, yeah? And then I have judged her to say, this is so inefficient, this will never work. And, and there's no one disease above the other. I think we've heard, I just wanted to know, it was easier to convince someone with a disease, but there's so much sensitivity. And please, in the audience, there is 420 people watching us today. And I think it's really a message of hope that you just gave everyone. But it's not an easy journey. If I can
exactly. I want to chime in because for me, the one thing I really learned, I picked up from all 4 panelists, is the importance of partnership. I mean, we've heard from each one that, it's very important to be able to identify people who are like-minded, people who have the same passion and same objective, and being able to champion a cause together. And I think for the PAGs, and especially if you're a patient advocate of a disease that is not maybe as popular as cancer or anything, don't feel alone. I think you need maybe to reach out to people who can partner with you, because you are not alone. And I think the example from Nidhi showed us that, and I'm sure the stories of our 4 other panelists are equally as inspiring to you. So maybe at this point, Maryline, we can bring out Jeff and Sejal.
They're all here. They were all brought in. And I think they started by telling us some sort of structure and knowing the people. I want to hear from them. You've heard, and then I want to hear back from each of you that have heard the case study of each other and ask questions, challenge, or is it any reactions? Because what we're looking at is one of the key learnings from this session. What are we taking away? What are we telling the audience the one thing? And is there not somehow a uniform standard challenge across? I've heard the same thing. And didn't you all wanted to collaborate and have a unified voice? I mean, I've heard it so many times. So each of you shout out so that I don't have to call you, and Joy and I have an easy listening here. Sejal,
I'm going to actually, I'm going to start. So shout out my name, or I'll shout out my response. Those were really some fantastic presentations. And Maryline, as you said earlier, Jeff and I are nominally the experts, but really the experts we heard from the PAGs, and any of the points that Professor Lim, Jeff, and I made, I think were just reinforced by the stories that Carmen, Derick, Tanya had shared, as well as Nidhi. And I think for me, what it keeps coming back down to, similar to what Joy said, is partnerships and connection. It's connection between people, and that there is a person behind the policymaker, understanding who they are, what motivates them. There are people that we're trying to tell the policymakers, we're not just numbers, we're people, we're patients, and understanding at the end of the day, people talking to people. And I think the more we start bringing it down to that and understanding who are those people, what health experiences have they had and have shaped them, how do we connect to them? And on either side, whether you're the patient, the policymaker, the practitioner, I think that is the real powerful aspect for me. And then when Derick had also mentioned bringing scientists together with policymakers and practitioners, that's very powerful. So it's getting people who normally, see themselves as these individual groups. I'm a patient, I'm a policymaker, I'm a scientist, to just stop with the labels for a second and just say we're people. we have a common issue, and let's just talk to each other. And I think, if we can just kind of boil down to that simplicity, it'd be wonderful.
So from my side, I thought a really inspiring and amazing stories, from each of the case studies, and I kind of noted down like maybe one key thing I took away from each one, and just kind of in no particular order, maybe roughly in the order they presented, but it all kind of came back to what we talked about earlier. So from Derick, for instance, I think Sajal just references. I really like the idea of not just sort of going out to find the people we need to do, but actually convening them. Being the one that brings them together and encouraging that dialogue. I think that's a great approach. Tanya, I think you targeted or mentioned about how you frame the story for the particular group of patients you're talking about. Because I guess in a way, to recognize that you're sort of competing in a marketplace of ideas, as they say, right? And so, if say cancer gets a lot of the attention, and you have cardiovascular, the processional cardiovascular, it's really important that you frame the story for that group of patients. And I was thinking even more relevant, let's say, for people with rare diseases, right, who don't get the attention. But I like the way that you frame the story for your group of patients to make sure they get heard. Carmen, I think a lot of great stuff there, but I guess maybe two things I picked up. One was that the way you cast a very wide net in terms of the sort of stakeholders that you engage with, right? Really wide net. And I think, also I guess a bit convening them. But the other thing I think very important is the way, you identified the kind of the personal stories of the people you're talking to as well. Like, do they have someone close to them with cancer, or, for example? So yes, you come with, with evidence and data, but again, people are people, so they have their own motivations, and understanding the personal stories, I think was really great. And last but not least, Nidhi, I think a couple things. One, again, I like the story about looking for maybe unlikely stakeholders, like your Minister of Tribal Affairs, right? So, looking across all of government and other organizations, there may be specific, may say ministries or organizations that may be looking after a certain population of people, or have, whether it's, the tribal people, it could be, elderly, it could be, students, whatever that is, but look, maybe, be open to look beyond the normal stakeholders, right? And I think the last point, which I guess in a way was sort of obvious, is but the idea of, the mobilizer. I hesitate to say, Novartis, it's the mobilizer, because obviously Novartis has mobilized this whole event in a way. But I think it's also a good point too, is look for, for a patient group is, you can have friends with resources, shall we say, and if a pharma company or another large organization that you can tap into their resources and network, absolutely. So that was kind of the things I picked up from each of that I really thought was interesting.
Is it okay if I just make a comment to that, actually, because I just want to make it really clear that, in Australia, patient groups don't like to see that we're, or think of it as though we're competing with each other. We're absolutely not. I think every disease is as important as the other, whether it be rare or whether it be cardiovascular disease, right? And in fact, and one thing I didn't speak to was that while we collaborate with all of the other stakeholders, we also collaborate with other patient groups. And that's really, really important. And I think especially for those who are just starting out too, because we are all really open to sharing resources, sharing our experience, sharing guidance, So I think that's a really important thing to consider, because a lot of the patient groups have already gone through the process. And in addition, I think when there's a need for health policy change, there's a power in numbers and a power, in numbers with patients. So you can certainly look to collaborate on, if there are, again, health policy things that really need the patient's voice, and you don't need to necessarily go to other stakeholders. You can do it as a collaboration. So I just wanted to make that really clear that, obviously it's really important to raise the profile in our own disease state that we're advocating for, but we certainly support each other, and we don't, it's about every disease case state getting the awareness that it needs.
Thank you for clarifying this point. if it needed to be. Derick, Carmen, you need to react.
Yeah, I totally agree. I think the phrase that we use is patience plus. And I think from a health policy perspective, it's very easy. And we've heard examples of where today, where you get pigeonholed, you get put into a kind of a corner from a health policy perspective. But by bringing that additional patient voice, but also the clinical voice and the scientific voice, that's often the leveler from a health policy perspective, that it's not just, I guess, what you might call special pleading. This is actually a concerted approach. It's evidence-based. It's bringing multitude of voices together. That is, again, coming back to what motivates health policymakers, is that they are designing policy that can do the most for the most people. But what often the difficulty for an awful lot of particularly rare disease patient groups is that you do get pigeonholed in your disease area, and that's a huge challenge to combat. But the Patients Plus approach, we find, actually really helps overcome that.
And I think especially during COVID times, we found that because the cancer community had a stronger voice, that we were in a position to, for example, help lupus patients to get free HCQ, or to be able to help transplant patients, again, to be able to get medicines. But I wanted to add very quickly to the people-to-people connection. We have to be aware that it's not only patients who lack confidence in terms of shaping policy. We sometimes have new legislators or even experienced legislators who may be in a position to make decisions in terms of health policy, but are not medical professionals and feel that they are not really the best persons to talk to. When we started advocating to the health of our health committee, who was newly assigned, he wasn't a doctor, and his first response was, I don't know anything about cancer, I'm not medically inclined, I think you're in the wrong office. But we knew that his wife had just been diagnosed with breast cancer. So in a very subtle way, we said we heard that cancer had knocked on your family's door. And in the cancer community, we say when you've traveled the journey, you become an expert in the disease. And then he suddenly went, and then he told staff, okay, meet with them, make this a priority. So we have to realize that it's not just us who lack confidence. They also need us to make them feel that their voice is important.
Thank you, Carmen. Nidhi, we're out of time, so you're going to have to do it super briefly, because I'm going to get so many messages to close this panel that would not finish, by the way. We can take it offline, guys.
Thank you so much. Thank you, everyone, for the lovely presentations and your stories. I just wanted to add that, the basic step is we are people, but we should also realize governments are people as well. They are mostly fragmented, driven by agendas of governments that are 4 years at length, maybe, and then it changes, and even within the Ministry of Health, there is so many, so many departments, so don't get overwhelmed by that. So I always, at least, when we work together, the first thing we try to see is what's the decision-making map, who plays a role, and where does that person sit, and what does they do, what their objectives are officially, and of course, personal objectives when it comes to publications, for example, and media presence, for example. So please start with that, and that would allow you to map really very well what would be your forthcoming strategy. So that would be my recommendation.
Thank you, thank you. And Joy, do you think we can have the poll results to see if any of our speakers have given a hope?
I was about to ask, so Sunil, can you please help us bring up the results of our poll, please?
We'll speak behind the screen. Did we give hope? We did. Is it? I can't see, it's too small for me, but
yes. So about half said that they're now moderately confident that tags can be involved, and close second, I guess, the second big piece is highly confident with 29%. So I think it really made a difference to hear all of these success stories as best practice. And I'm sure all of our participants are looking forward to really crack their heads and get into the challenges and how they can solve them together.
If we can have the 8 people back on the screen, you're not in real, in a real room, but there are 400 people that are clapping and say thank you to you. So I think I'd like to show this. Where are the people? Here they are. I want to do it. It's 420 people doing this, and that's the best I can do now. But thank you so much. This was incredible. I know we could have lasted for a lot longer. There are a lot of questions, a lot of comments that came through the chat, so we'll have a discussion post this. I have the hard duty to say that we're reducing the break by 5 minutes because we run over a little bit. So here is break time. Come back to the plenary in a few minutes so that we can go and discuss in the breakout rooms in each country. Okay, what's the plan now? What is the plan? And appreciate everyone to come back in 5 minutes. And thank you so much for all the participants and this extreme, they're back here, yeah, extreme panel. Thank you. I have to stop saying thank you.